Thank you, madam. A very good afternoon to all of you. When headache means more in a child, so I'll be talking about a common presentation of a very rare disease. So our patient was a 10-year-old boy who was apparently well before. He first presented to the pediatric outpatient by the pediatric team and referred to us very late in the course. So, but I will start from the beginning. So he was apparently well before and first presented in January 2025. He had an episodic headache since December 2024, which was mild to moderate in intensity. He had about 2 to 3 attacks a week, each episode lasting about half an hour to few hours. And this was associated with some nausea and giddiness. And most episodes were relieved after vomiting and at times after having a little nap. So he denied any preceding aura or any photo or phonophobia. And he denied any particular aggravating or relieving factors. There were no ENT or respiratory complaints. There were no behavioral changes, no memory issues, and he denied any stress related to academic or household issues. And interestingly, there were 3 episodes of very severe headaches associated with left-sided weakness and numbness, face, arm, leg weakness and numbness associated with falls as well. So the headache as well as the weakness improved over about half an hour along with the analgesics and rest. So out of these 3 episodes, the first episode occurred when he was waking up from sleep in the morning, and the second one while he was eating. Third one, again, early morning, but he was not asleep. There were no neurological symptoms. Vision was fine, swallowing, speech, memory, everything were okay. And during the episodes, there was no loss of consciousness, no fits, no bladder bowel incontinence, and he denied any systemic symptoms such as fever, loss of appetite, or loss of weight. And the detailed systemic inquiry did not reveal any other significant abnormality. So his birth history was significant. He was delivered at 32 weeks of gestation with an emergency section. Indication was not very clearly mentioned, but I'm guessing it's IUGR because the birth weight was 1.6 kilos. PBU care was given, and he had prolonged neonatal jaundice for which he received phototherapy. Despite the stormy neonatal period, his development was age appropriate. There were no delays, and the current school performance was also average. Immunization was up to date. There was no family history of any epilepsy syndromes, young stroke. However, her sister claimed to be having migraine. He was a product of non-consanguineous parents, and he had 1 elder sister. So these are the examination findings. So the general examination revealed a BMI of 19.74, which is between +1 SD to +2 SD. He was overweight. And there was mild acanthosis nigricans. There were no cutaneous stigmata of any neurocutaneous syndrome or any other autoimmune connective tissue disease or vasculitis, and he was not pale or icteric. Neurological examination, the fundus was essentially normal. There was no pronated drift, no limb weakness or numbness. There were bilateral downgoing plantar reflexes, no cerebellar signs, and the cranial nerves were intact. Cardiovascular system examination revealed a pulse rate of 88 beats per minute, regular, without delays. All the peripheral pulses were intact, no bruise. Blood pressure was 112/76, which is 90th percentile value, which is in the upper limit for his age. Heart was in dual rhythm without any murmurs. Other systems were unremarkable. So What are the differentials you're thinking of? So these were the differentials entertained by the pediatric team at that time. So migraine was a possibility, particularly the hemiplegic migraine. And because of the early morning headaches, which were relieved by vomiting, they were also thinking of any structural cause, a space-occupying lesion. And obviously, because of the neurological symptoms, TIA was also a possibility. And even though the headaches were not particularly thunderclap, and reversible cerebral vasoconstriction was also considered. And then again, focal epilepsies and tension headaches were also considered. So, keeping hemiplegic migraine as the tentative diagnosis, they have started flunarizine 5 milligrams nocte while awaiting the blood workup and the imaging studies. Interestingly, there was a reasonable response to flunarizine. Headaches became less severe and less frequent. And there were no further episodes of limb weakness or numbness while on flunarizine. So these are the basic investigations done initially. Full blood count was normal, WBC normal with a normal differential count, hemoglobin normal, platelets normal, creatinine and electrolytes normal, transaminases normal, ESR and CRP both were normal. Fasting blood sugar was normal. His LDL was a little to the high side with a cholesterol to HDL ratio of 4.59. Thyroid functions normal. He got the chance of getting the EEG done before for any other imaging. So EEG was showing evidence of a focal irritative zone over the right posterior region. So what is this? Could this be a space-occupying lesion? So the team was alarmed. They started levetiracetam prophylaxis while awaiting further imaging. So these are the findings of the MRI, MRA, and the MRV he had. So there were bilateral old superior cerebellar infarcts, larger on the right side, and a small volume infarct in the left inferior cerebellum as well. No high-grade narrowing of bilateral vertebral arteries, no intracranial proximal artery occlusion. So the MRA and the MRV were essentially normal, and the MRI was showing cerebellar infarcts, which were old. So this is the first MRI that he had. I have indicated the infarctions with the arrows, if you can appreciate. So on the right side, there is a big infarct. So this is young stroke. So they started digging deeper for the cause. So these are the other investigations that the child had. APTT was normal, antiphospholipid screening was negative, and factor V laden mutation and MTHFR gene mutation were negative. Protein C and S levels were normal. We could not get a homocysteine level done. ANA was negative. C and P ANCA were negative. They have repeated the inflammatory markers. Again, they were normal. Bilateral carotid and vertebral artery Doppler were negative. ECG was only showing a sinus arrhythmia. And the echo was showed a structurally and functionally normal heart. Lumbar puncture was offered, but they could not obtain consent from the parents to proceed with this, so it was not done. So at this point, aspirin was added to the management and levetiracetam was continued. Obviously, flunarizine was stopped. And the patient was referred to the nutrition team to optimize his weight because he was overweight and the blood pressure was also borderline. And then for a more detailed assessment of the neck vessels, a CT angiogram of the head and neck was planned. So these are the findings of the CT angiogram. The old infarctions and encephalomalacia, which was seen earlier, they were evident on the CT again. There was no carotid-vertebral artery dissection. Posterior communicating artery was hypoplastic, which was an anatomical variant. However, there were no features of large to medium vessel vasculitis evident on the angiogram. Extracranial carotid and vertebral arteries were essentially normal. So these are the pictures of the angiogram. So the first two are the normal vessels, and the picture below is showing the old infarct. So talking about the clinical progression, so this child was still having episodic headaches with similar semiology, but they were less severe and less frequent. At this point, the team has added topiramate 25 milligrams BD as well. Aspirin dose was increased to 100 nocte. There were no further episodes of weakness or numbness until August 2025. On the 11th of August, there was a recurrence of left-sided face arm leg numbness, not the weakness, just a numbness, along with a severe headache again. This also settled with analgesics after about half an hour. So at this point, the pediatric team had decided to repeat the imaging. So the repeat MRI again showed bilateral cerebellar infarcts similar to before. There were no new infarcts. However, there was a comment on the MRA saying that there was a gradual tapering of the right posterior cerebral artery in the ambient system compared to the left. This could be non-specific. It's not suggestive of vasculitis per se, but there is a suspicion. And they have also commented that the tortuosity of the upper cervical carotids and the upper vertebral arteries were more. However, there were no typical features of vasculitis. There was no vascular bleeding, no narrowing or occlusion. So the findings were inconclusive. At this point, before that, I'll show you the pictures. This is the MRI showing the old infarcts. I have indicated with the orange arrows the infarcts. And this is the MRA, which is again not showing typical vasculitis features, but the report was saying very inconclusive things, but there was still a suspicion. So at this point, they decided to proceed with a 4-vessel cerebral DSA. This was done at the NHSL. Unfortunately, I could not get hold of this films because there was only a printed report. CD or the films were not given to the child. So this is the report. It's saying that P4 and P5 segments of bilateral posterior cerebral arteries are not visualized, although the typical puff of smoke appearance was not seen. And there was mild wall irregularity of V3 and V4 segments of the left vertebral artery. And they have commented that these appearances are in favor of early vasculitis. So at this point only, this patient was referred to us. So there was we again obtained a detailed history and we repeated the clinical examination. But we could not find any features to suggest any extracranial small to large vessel vasculitis. We particularly looked for Takayasu, polyarteritis nodosa, sarcoidosis, Pesce, and even ANCA vasculitis, but there were no features to suggest whatsoever. And the patient was, at this point, patient was having daily headaches again, but there were no neurological symptoms. And he denied any significant systemic symptoms as well. We repeated the inflammatory markers, again, normal. UFR was normal. We requested for a repeat CT arch aortogram, which did not show any significant abnormality. So the extracranial arterial system was also normal. Hepatitis B and C screening negative, HIV screening negative, MAN2 negative, VDRL non-reactive, and procalcitonin was normal. Right, so is this primary CNS vasculitis? This is what we thought of. So giving the benefit of doubt to the patient, we thought of giving a steroid trial. So we pulsed him with, because the procalcitonin was normal, he was not systemically unwell, infection was very, very unlikely. So we pulsed him with 3 pulses of methylprednisolone 500, and interestingly, there was a complete resolution of the headache and patient was feeling very well. So after this, there was a MDT discussion to plan the future management with the participation of the pediatrician, the pediatric neurologist, adult neurologist, and the neuroradiologist and hematologist. So this is the summary of the MDT discussion. There were suggestive changes in the DSA to say that there is some vasculitis going on in the CNS, and the extracranial imaging was negative for any abnormality, and the thrombophilia screening was negative. And we could not find any other treatable cause, and most importantly, there was a good response to steroid as well. So considering all of these, there was a decision to manage this patient as a case of primary CNS vasculitis. So actually, the confirmatory test was a brain biopsy. This was discussed at the MDT, but since our patient had posterior fossa changes, the biopsy is anyway going to be technically challenging. And obviously, after explanation, parents did not give the consent for that. They didn't even consent for the lumbar puncture, so it was very difficult to get the consent for this. So, and we decided to escalate the immunosuppression. The MDT decision was to go ahead with rituximab. Actually, there were several reasons for this. One thing is that we did not confirm the disease by a biopsy. So it's still there could be, this could be something else as well. And so we did not want to go for a more stronger medication, because we haven't even done a LP to rule out malignancy, infection. So we thought of trying a milder thing before going ahead with cyclophosphamide. And also obviously the side effect profile was also a concern. So he was given IV rituximab, 375 milligrams per square meter weekly for 4 weeks, along with oral prednisolone, 1 milligram per kg with gradual tapering down. And we followed more or less the same protocol as for giant cell arteritis when we were tapering the steroids. So what happened next? There was a recurrence of headache when he came down to prednisolone 20 milligrams daily. So at this point, we thought of adding mycophenolate as a steroid sparer. And then we slowed down the tapering speed as well. And then suddenly, he again started having problems. So there was a very severe headache followed by left-sided face arm leg weakness, while on prednisolone and MMF. And this time, the weakness did not improve. It was persistent. However, he did not have any altered level of consciousness, no seizures, no systemic symptoms. And on examination, there was gross weakness on the left side, 2 out of 5, with sensory impairment as well. So this was clearly an indication to repeat the imaging. This is the finding of the repeat MRI and the MRA. There was an acute infarct in the posterior limb of the right internal capsule, and then a subacute right thalamic infarct as well, which has happened in between the August MRI and this was done in February, actually, the last one. So the lesions have progressed. And then there was interval new reduced flow related signals in the normal basilar origin left posterior cerebral artery. And there was reduced flow-related signals on both superior cerebral arteries as well. And asymmetry of the right posterior cerebral artery similar to the previous MRI. And then expected interval evolution of bilateral old cerebellar infarcts. So this is the MRI. I have indicated with the arrows the new internal capsular infarct, and I'll show you a more clearer picture. So the first image on the right-hand side is showing the it's DWI images showing the new internal capsular infarct, and the second one on the top is showing the subacute thalamic infarct in the FLAIR, T2 FLAIR image, and on the bottom image, the old cerebellar infarcts. And this is the angiogram. I have indicated with the green arrow. So on the other side, you can see the posterior cerebral artery is continuous, but on the right-hand side, that continuation is not clearly seen. This was the only clearer picture that I could take out of the images available. So this was showing obliteration of the posterior cerebral artery. So at this point, because of this new clinical deterioration, we decided to escalate the immunosuppression. He was again given IV methylprednisolone passes for 5 days, followed by a dose increment to the oral prednisolone. And then we decided to proceed with cyclophosphamide. 15 milligrams per kg was the dose that we used, and we followed the vasculitis regime, the 0, 2, 4, 7, 10, 13 week cyclophosphamide regime, and he has so far received 3 doses. He's doing quite well now. Left-sided weakness is gradually improving. On the latest assessment, he had 4- out of 5 power, and he's headache-free, and he's currently on regular physiotherapy and occupational therapy as well. So before moving on to discuss about primary CNS vasculitis, I just thought of comparing this primary CNS vasculitis with autoimmune encephalitis to highlight why we didn't think of autoimmune encephalitis as the cause for this patient's symptoms. So the target is essentially different. In primary CNS vasculitis, it's the vasculature that is involved, leading to vascular occlusion, ischemia, and stroke. Whereas in autoimmune encephalitis, it's the brain parenchyma that gets involved, and there are antibody and T-cell mediated damage to the neurons. And the common symptoms, the primary CNS vasculitis usually presents with chronic headaches and recurrent strokes and a gradual cognitive decline. Whereas in autoimmune encephalitis, it's a very subacute cause of neuropsychiatric, memory loss, seizures, behavioral changes, psychiatric symptoms, psychosis, agitation sort of picture predominates in autoimmune encephalitis. And the imaging, so vessel wall imaging is a special technique that we follow in MRI. And also in MRA, you can see this beading appearance. So alternating stenotic and dilated changes over the vessels seen on the in primary CNS vasculitis. Whereas in autoimmune encephalitis, you see T2 and FLAIR hyperintensities often in the limbic system, the hippocampus. So talking about the definitive test for diagnosis, for primary CNS vasculitis, it's the brain biopsy, which we could not do yet. And then for the autoimmune encephalitis, it's the antibody testing in the serum or the CSF, the anti-NMDAR and LGI1 antibodies, etc. So moving on to primary CNS vasculitis or primary angiitis of the CNS. So this is a very rare inflammatory disorder affecting the blood vessels of the brain and the spinal cord without any systemic involvement or underlying connective tissue disease. So childhood primary CNS vasculitis accounts for about 2 to 6% of the pediatric cerebral arteriopathies. So there are no validated diagnostic criteria for this, but there is one criteria laid down by Calabrese and Malik. It's a diagnosis is made if all of the three criteria are met. Out of that, number one is the presence of an unexplained acquired neurological deficit after extensive investigation for other causes. Number two, presence of evidence of an inflammatory arthritic process within the CNS, either by angiography or histopathology, or both. And number three, no evidence of any other systemic vasculitis or any other disorder to which the angiographic or histopathologic features can be secondary to. So those are the criteria. So there are several types of primary CNS vasculitis. It can be broadly categorized into angiography positive and angiography negative. So in angiography positive, there is non-progressive variety and a progressive variety. So the non-progressive one is usually a large vessel vasculitis, which occurs in proximal large vessels with subsequent focal stenosis, and they usually present with sudden onset, very acute neurological events such as hemiplegia or a symptomatic seizure corresponding to that particular vascular territory. So this is usually a monophasic event and it does not progress beyond 3 months. So the progressive variety, it's a large to medium vessel vasculitis. So you can see multifocal MRI lesions and evidence of both proximal as well as distal vessel stenosis on the angiography. And the symptoms are also both focal as well as diffuse. That means strokes, seizures, as well as cognitive decline, psychiatric changes, behavioral changes, and all. And untreated patients usually progress beyond 3 months. And the angiography negative variety is a small vessel vasculitis. On the MRI, there are multifocal white matter abnormalities seen, but the angiography is usually negative. And then the presentation is usually subacute with multifocal neurological deficits, headaches, neurobehavioral, and cognitive decline. And seizures and tumor-like presentations may also occur in this variety. And this is essentially a progressive disease. So here I have put down a chart which I took from a review article in NEGM, summarizing the clinical manifestations of primary CNS vasculitis, and they have mentioned the percentages in 2 different cohorts. So focal neurological deficits, headaches, cognitive impairment, speech disorder, aphasia or dysarthria, and visual symptoms, ataxia, seizures, vertigo and dizziness, fever, which is very, very rare. About in one cohort it was 9%, and on the other it was 7%. And intracranial hemorrhages occur at times, and also psychiatric disorders and amnestic syndromes have been reported. So this chart, I'm not sure whether it's very clear or not. It's mentioning the special and rare clinical manifestations of primary CNS vasculitis, which mimics other conditions. In the interest of time, I will not go through this in detail. So talking about differential diagnosis for primary CNS vasculitis. So we'll talk about non-vasculitic mimickers first. So there are mimickers for angiography positive disease and angiography negative disease. So for the positive disease, atheroembolic phenomena and fibromuscular dysplasia, moya-moya disease, and post-subarachnoid vasospasm, antiphospholipid syndrome and other prothrombotic states giving rise to vessel occlusion, and also primary CNS lymphoma and intravascular lymphoma are the differentials. And for angiography negative small vessel disease, mock encephalitis, CADASIL, CARASIL, and reversible cerebral vasoconstriction syndrome and cerebral amyloid angiopathy are the possible differentials. So the systemic diseases that can cause CNS vasculitis, so obviously the connective tissue disease and other autoimmune diseases like SLE, Sjogren's, dermatomyositis, RA, IBD have been reported to cause CNS vasculitis. And then systemic vasculitis, most importantly Behçet, which has a 5.3 to 14.3% CNS involvement. And neurosarcoidosis, GPA, EGPA, cryoglobuliniemias, GCA, Takayasu all can cause CNS involvement. And infection, so viral infection like varicella, HIV, hepatitis C, parvovirus B19 can cause CNS vasculitis. Bacteria such as TB, Borrelia, syphilis can cause CNS vasculitis, and fungi like Aspergillus and Candida also can cause CNS vasculitis. Talking a bit about cerebral amyloid angiopathy, it's a mimicker of primary CNS vasculitis, and sometimes they say that these two conditions coexist. There are two different disease conditions, but their symptoms overlap. So cerebral amyloid angiopathy, it involves, it's a non-inflammatory arteriopathy where you get beta amyloid deposits in the leptomeningeal arteries, which leads to vessel wall damage and lobar hemorrhages and a very gradual cognitive decline. This is the classic CAA. But there is an inflammatory subtype of CAA which mimics primary CNS vasculitis, which usually runs a subacute course with cognitive decline, and this variety actually responds to steroids as well. So the brain biopsy is the gold standard in diagnosing this, and in amyloid angiopathy, obviously you will see beta amyloid deposition on immunostaining. So how to diagnose primary CNS vasculitis? So the diagnosis is difficult because of the absence of specific biomarkers and the non-specific nature of the symptoms. Inflammatory markers are usually normal because there's no systemic involvement, and ANA can be positive at times. So there is a place for CSF examination. You will usually see a pleocytosis and a slight increase in protein levels with normal sugar levels. So the place of CSF examination is mainly to rule out other causes like infection and malignancies by cytology and cultures. That is the main importance of doing a CSF analysis in this case. And CT angiogram and MRA are usually the first line imaging studies. However, the DSA, it's superior to MRA and the CTA, particularly to have a look at the medium-sized vessels. So European Stroke Organization recommends to proceed with a DSA if the CTA and the MRA are negative. So the usual angiographic abnormalities that you see are the segments of stenosis with post-stenotic dilatation giving rise to the beaded appearance, and also you could see aneurysms and also arterial occlusion in medium to large vessels. So there is this special imaging modality called high-resolution vessel wall imaging in MRI, which has emerged as a supplementary diagnostic tool. It's capable of identifying vessel wall pathology beyond the luminal changes, and there is concentric enhancement of the involved vessels if there is vasculitis, which is observed in this imaging modality. Right, so these I have got down these images from a review article. So the first two images, A and B, A is a MRA and B is a DSA, showing alternating stenosis and dilatation, the beaded appearance of the left anterior cerebral artery and the left middle cerebral artery, if you can appreciate it. And then the picture C and D. So the picture C is picture C and D are vessel wall imaging, and C is before contrast and D is post contrast. And I have indicated with the orange arrow the place where there is enhancement of the right middle cerebral artery. This represents possible vasculitis. And pictures at the bottom, E and F. So E is a DWI showing a recent acute infarct, and picture F is a T2 flare showing chronic infarctions in the right middle cerebral artery territory. So these are the classic findings you could see on images of primary CNS vasculitis. So how do you diagnose if angiography is negative? So brain biopsy comes to play at this point. So brain biopsy is the gold standard in diagnosing CNS vasculitis. This is usually if the imaging cannot detect vasculitis, and if there is high index of suspicion, you should proceed with the biopsy ideally. And even if the imaging is positive, at times it's very difficult to differentiate vasculopathy from vasculitis just by the imaging itself. So there is always a place for brain biopsy if there is any doubt or suspicion. The sensitivity of the biopsies are low, but the specificity is very, very high. You should obtain a full thickness brain biopsy sample containing parenchyma and the leptomeninges. It's better if you could obtain the biopsy from an area where there are imaging abnormalities to increase the sensitivity. Otherwise, if you're going for a blind biopsy, they usually recommend to biopsy the non-dominant frontal cortex. So there are three histological types of primary CNS vasculitis. Number one, the granulomatous lesions, which are the most commonest ones, where you see well-formed granulomas with multinucleated giant cells. And then there are lymphocytic lesions, which are usually less aggressive than the other two forms. And then also necrotizing lesions, where you see transmural fibrinoid necrosis similar to PAN. And this variety usually leads to hemorrhages as well. So these are a few slides of histological slides. The first one, A, is showing granulomatous vasculitis with some amyloid deposition as well. So the B is the same sample with immune staining. So the brown staining is showing amyloid deposits. So I mentioned earlier that amyloid angiitis can overlap with primary CNS vasculitis. So this is something like that. And picture C is showing the lymphocytic vasculitis with extensive lymphocyte infiltration, perivascular as well as transmural. And picture D is showing fibrinoid necrosis, the necrotizing variety. So talking about the treatment, there's no evidence-based recommendations from randomized controlled trials available yet. So the current treatment protocols have been based on primarily on the retrospective cohort studies. So there are two phases of treatment, remission induction and remission maintenance. So for the remission induction, IV methylprednisolone 1 gram daily for 3 to 5 days, followed by oral prednisolone 1 milligram per kg with gradually tapering down. And so the steroids are enough for mild diseases actually, but if the cases are severe or if they are relapsing, then you should proceed with another immunosuppressive agent as well. So the most evidence are for cyclophosphamide. There's no consensus on the regime. You could either use monthly pulses for 6 months or the one that we use, the vasculitis regime. And then if there are contraindications or intolerances to cyclophosphamide, you could treat with MMF. So there are observational uncontrolled two studies saying that it's equally effective to cyclophosphamide. So if there are contraindications or intolerances to both of these, you could also proceed with rituximab or tocilizumab as well. So the remission maintenance is they advise to continue remission maintenance at least for 2 years. This is usually with MMF or azathioprine. And then the European guidelines suggest adjunctive aspirin therapy for patients with medium to large vessel involvement as well. So talking about the course and the prognosis, it's essentially variable. Good neurological functional status with low modified ranking scale is observed in about 46 to 73% of the patients in one study. And the factors associated with poor therapeutic response and long-term disability and death are the old age at the diagnosis and delay in diagnosis and cognitive dysfunction at presentation and spinal cord involvement, medium to large vessel vasculitis and cerebral infarctions on imaging and the male sex, and then active lesions with gadolinium enhancement on imaging is also associated with a relapsing course. So the refractory disease is defined by the non-response to induction therapy or a lack of complete remission. So in such instances, it is very important to revisit the diagnosis and consider other potential differentials and to consider a brain biopsy if the condition was solely diagnosed by angiography. So serial MRI and MRAs every 4 to 6 months or when a new neurological symptom arises along with regular neurological examination are important in monitoring the disease activity and adjusting the treatment. So without any other symptoms of active vasculitis, persistent vessel wall enhancement on MRA or showing lack of, or the MRA showing lack of improvement on the imaging, they don't clearly warrant intensification of immunosuppressive therapy. You should always go by the clinical picture. So in summary, primary CNS vasculitis is a rare disease that affects the brain and the spinal cord with a range of non-specific neurological symptoms. So diagnosis relies on the findings on the brain MRI, CTA, MRA, and the DSA, and also with the cerebral biopsy on ruling out other alternative causes. So the size of the predominantly affected arteries allow categorization of the disease into small vessel and medium to large vessel, which have distinct clinical characteristics and outcomes. And the management of this condition involves balancing immunosuppressive therapy against their potential risks. So future scope, future research could define the underlying pathophysiology, which is not very clearly established yet, and then discover biomarkers and refine the diagnostic criteria and treatment for this disorder. So these are my references. I have put a picture of the review article that I used from the NEJM. So I would like to thank my patient and his parents and Dr. Buddhika Jayaratna, my colleague, the other consultant rheumatologist at Teaching Hospital Anuradhapura, and Dr. Nadun Vithanage, the consultant neuroradiologist who helped me with the images, and obviously all the team members of the multidisciplinary team, all the consultants, junior doctors, nurses, and the supporting staff. Thank you.
Thank you, Dilmi, for the most enlightening lecture. It's time for questions if the audience has any. So, any questions, comments?